Dear colleagues, it is my pleasure to share Dr. Imad this meeting about one of the important topics in the field of endoscopic ultrasound and pancreatology, which is role of endoscopic ultrasound in diagnosis and management of neuroendocrine tumors. Pancreatic neuroendocrine tumors represents about 10 to 25% of all neuroendocrine tumors, and it represents about 5 to 10% of all pancreatic tumors. We all know that 1/3 is functioning, like insulinoma, gastrinoma, and somatostatoma, and so on, and 2/3 of the neuroendocrine tumor are non-functioning tumors. Imaging is very critical to localize primary neoplasms and detect distant metastases. We can do that by many imaging modalities like CT, MRI, PET scan, gallium dotatate PET scan, somatostatin receptor scintigraphy, and endoscopic ultrasound. Today, I will talk about the role of endoscopic ultrasound in this very important subject. My agenda will include diagnosis, including detection of small tumors not seen by CT or MRI or gallium dotatate PET scan, and staging of this tumor for possible surgery or chemotherapy, and also will include tissue sampling, FNA, FNB, and interventional techniques like tattooing of small focal lesions before the planned surgical treatment, fiducial mark placement for further stereotatic treatment, and the most important promising technique now in the last few years, which is EUS radiofrequency ablation. Let us start in the first task of endoscopic ultrasonography, which is diagnosis of NET. Endoscopic ultrasound is the most sensitive imaging modality for pancreatic NET. Sensitivity reaches up to 85 to 94%. It detects lesions of few millimeters in diameter. Diagnostic sensitivity of pancreatic insulinoma is up to 94 to 100%, very sensitive. Diagnostic sensitivity of pancreatic gastrinoma is nearly 100%. So we can say that a negative endoscopic ultrasound practically exclude the presence of pancreatic tumors. And it is now used as a preferred screening methods in patients with endocrine neoplasia type 1. And of course, it can stage pancreatic neuroendocrine tumor for resectability. So, as I mentioned before, EUS is the first modality of choice in diagnosis of neuroendocrine tumors in selenoma, because it can detect tumors as small as 3 millimeters, and these tumors is usually missed by CT or MRI. And it is one of the very good choices in diagnosis of gastrinoma, glucagonoma, somatostatinoma, VPOMA, and also non-functioning neuroendocrine tumors. This is the TNM staging of neuroendocrine tumors. It is somewhat like that of pancreatic duct adenocarcinoma. T1 are tumors restricted to the pancreas and smaller than 2 centimeters. T2 are tumors limited to the pancreas and between 2 and 4 centimeters. T3 are tumors limited to the pancreas and more than 4 centimeters, or tumors invading the duodenum or common bile duct. T4, which is unresectable tumors, tumors invading adjacent organs like the stomach, spleen, colon, adrenal glands, or the wall of large vessels, large arteries, specifically celiac axis or the superior mesenteric artery. This is a video representing a T2 resectable neuroendocrine tumor. Now we're scanning from the gastric body, and this is the venous confluence of portal vein, superior mesenteric vein, and splenic vein, and this is the splenic artery. There is a very good line, very clear line of interface between the mass and the venous confluence. And the mass is about 2.5 centimeter, so it is T2 resectable tumors. In contrast, this is another tumor located in the pancreatic body, and it is seen involving the whole circumference of the superior mesenteric artery. So it is encasing the superior mesenteric artery, yes, and also compressing and encasing the superior mesenteric artery. So it is unresectable tumor for chemotherapy. Now we will talk about the importance of endoscopic ultrasound tissue sampling in neuroendocrine tumor. It is important to differentiate it from other benign lesions as focal pancreatitis or malignant tumors as pancreatic duct adenocarcinoma and SPEN tumors, solid pseudopapillary epithelial neoplasm. And it is also important for proper pathological staging for further management, as I will mention later. And here, fine needle biopsy is better than fine needle aspiration because we can obtain sufficient tissue for immunophenotyping, especially synaptophysin and chromogranin. Actually, it is very easy to sample the tumor because it is very near to the echo endoscope, although it is usually slightly hypervascular, but it can be easily sampled. And this is the FNB needle. I usually use 22 needles, and it's very easy to obtain enough tissue for differentiation from other tumors and immune staining. This is the WHO classification. This is the old one in 2010, and this is the new one in 2017 and 2019. It classifies a neuroendocrine tumor into well-differentiated pan-neuroendocrine tumors, and this subclassified into 3 subclasses: grade 1, G1, grade 2, G2, and grade 3, and poorly differentiated pan-neuroendocrine carcinoma, small cell type and large cell type, and mixed neuroendocrine and non-neuroendocrine neoplasm. This is important for further management. This is a general algorithm we all know about management of neuroendocrine tumors. Tumors more than centimeter, non-functioning pancreatic net more than 2 centimeter, then you should send the patient for surgery. But functioning neuroendocrine tumor like insulinoma and gastrinoma should be sent to surgery regardless its size, even if it is few millimeters. But with proper histopathological examination, G1 neuroendocrine tumor less than 1 centimeter is justified for follow-up, and the endoscopic ultrasound radiofrequency ablation, the newly emerging technique, is justified in G1 neuroendocrine tumor with the size between 1 and 2 centimeter, while surgery is recommended in G2 neuroendocrine tumor between 1 and 2 centimeter because G2 tumors has a higher incidence of recurrence, so it is here surgery may be better than radiofrequency ablation. Now coming to the breakthrough through the last years, which is interventional endoscopic ultrasound, including the tattooing of small focal lesions before planned surgical treatment, as I mentioned before, and fiducial markers placement, metal rods for further stereotactic treatment, and the most important nowadays in the management of neuroendocrine tumor, which is EUS radiofrequency ablation and EUS ethanol ablation, but now ethanol ablation is not preferred to be done at all due to its serious side effects. Let us talk a little bit about EUS guided preoperative tattooing. EUS guided fine needle tattooing is a technique in which carbon article labels are injected into the pancreatic lesion via EUS guidance. These labels then serve as markers during laparoscopic distal pancreatectomy, which ultimately reduces operating time, cost, and amount of healthy pancreas that is resected. This is our case reports in gastrointestinal endoscopy in 2021. Here we inject the Indian ink or black eye into sites. The first one is at the upper aspect of the small tumor. And the second site is between the gastric wall and the upper aspect of the pancreas at the peritoneal reflection. During surgery, these 2 points are very clear. These 2 black points are very clear. So the tumor expected to be in this area. And here, this is the peritoneal point. So we can resect the tumor with appropriate safety margin. This is very beneficial when the tumor is deeply seated. It will not bulging on the surface. So it will not be seen during laparoscopic surgery, especially if it's small and deeply seated. This is tattooing is very beneficial, especially when the intraoperative ultrasonography is not available. Now coming to the most important part of my lecture, which is a very promising EUS guided radiofrequency ablation. Before going in this subject, I'd like to see with you this video. This video of a young man with severe bouts of hypoglycemia, sometimes so severe that necessitates hospital admission with neurologic deficit. Serum insulin and C-peptides are high, so this is a proper clinical and lab setting of insulinoma. Here, this is a well-defined mass. This mass is located at the neck of the pancreas as the venous confluence of the portal and superior mesenteric vein. So here the operation will be a major operation. It will be either an extended Whipple operation or extended distal pancreatectomy, a major operation, or enucleation, which is carries a high risk of leakage and fistulas formation. Whipple operation has a mortality of about 5 to 10% in best centers, and morbidity is up to 30%. Distal pancreatectomy has a leakage rate up to 30%, and enucleation has a complication, a famous complication, which is fistula formation in up to 30%. So what I'd like to say that sometimes you are obliged to do major surgery for small tumors and sometimes benign tumors like insulinoma. In addition, patient may be poor surgical risk due to comorbidities. Patients sometimes refuse major surgery, so there should be other modalities like radiofrequency ablation. The ideal ablation temperature is between 60 and 100 degrees centigrade. Below 60 degrees centigrade is sublethal, and above 100 degrees centigrade, charring occurs, and it is not desirable at all because charring may induce sticking of the needle to surrounding tissue. In addition, that it makes the tissues very friable with more liability to complications. So the rationale of EUS guided radiofrequency ablation in PNET is pancreatic neuroendocrine tumor smaller than 2 centimeters, especially if G1. If G2, we may do it for G2, but with a little bit higher incidence of recurrence. And also in pancreatic neuroendocrine tumor more than 2 centimeters in surgically unfit patients. Here, a good candidate for radiofrequency ablation is insulinomas gastrinoma, vipoma, somatostatinoma, but the most suitable one is insulinoma because insulinoma has a benign behavior in up to 90%. So it has a very low instance of recurrence. Gastrinoma is a little bit more aggressive, and also vipoma and somatostatinoma. The advantages of radiofrequency ablation is that it is minimally invasive and repeated treatment possible. We may do ablation to the second time if there is partial improvement. We can do it to second time and third time, and short-term recovery. It may be done in one day hospital admission. The adverse events are not so common, less than 5%, less than 5 to 10%, which include pancreatic duct stenosis, pancreatitis, pancreatic fistula, CVD stricture, or hematoma. Let us mention some of the important studies in this field, which is a French multi-center study by Marc Partey. Patients included are poor surgical risk patients, planned for 30 patients over 2 years, and this study included 12 patients with neuroendocrine tumor in between 1 and 2 centimeters. 3 complications occurs, 10% of the patient. The first 2 complications occurred in the first 3 patients. 1 case of pancreatitis, 1 delayed small bowel perforation, 1 pancreatic duct stenosis. So they changed the study protocol. They recommend prophylactic non-steroidal anti-inflammatory like ERCP and antibiotic prophylaxis before radiofrequency ablation, and avoid radiofrequency ablation close to the pancreatic duct. At 6 months, there is significant response, about 82%, and at 12 months, no recurrence occurred in the responder patients. In another systematic review in 2021, included 35 case reports and case series describing 75 patients with insulinomas. 27 patients were treated with EUS-guided radiofrequency ablation, and 47 patients with EUS ethanol ablation. 1 patient received both techniques. The clinical success was surprisingly very high. It is about 98.5%. The complications were more with alcohol or ethanol ablation. So now nearly all authors prefer radiofrequency ablation. The complications, the adverse events was reported in 11 cases, about 50% of the patients. Abdominal pain in 7 cases, 2 mild acute pancreatitis, 1 severe necrotizing acute pancreatitis, and 1 local hematoma. However, all patients recovered and there were no peri-procedural deaths. Here in Egypt, we start our experience, and this is a preliminary results. We did 11 cases of radiofrequency ablation of insulinomas, 8 males and 3 females, mean age 34 years. We did 15 sessions with total of 36 passes, median of 3 passes for each patient. We used 19G cooling EUS needle. No major complications or mortality for mean follow-up period of 12 months. There is post-procedural epigastric pains in 2 cases of insulinoma, decreased gradually over the following 3 weeks, not necessitating hospital admission. About our results, there was complete clinical cure of 10 out of 11 patients, about 91% with pancreatic insulinoma. However, 1 patient required 3 sessions for complete cure, and 2 patients required 2 sessions of radiofrequency ablation. The last patients with insulinoma showed partial response after 2 sessions of radiofrequency ablation with a slight decrease of severity, duration, and the number of attacks. These patients is poor surgically risk patients. So a third session was planned. This technique, we do it in many instances, which is a moving shot technique. We introduce the needle to the most distal part of the tumor and do one ablation, and then withdraw it, do a second ablation, and so on. My last slide is one of the cases. I'd like to show you the technique and some of the tips and tricks of this technique. It is a rather simple technique. This was a male patient, 37 years old, complaining of severe attacks of hypoglycemia, recurrent, so some neurological deficit occur. Serum insulin is high, serum C-peptide is high, and the endoscopic ultrasound showed a well-defined mass in the region of the head of the pancreas at the venous confluence. This is the mass, and now we are in the bulb of the duodenum, and this is the portal vein and splenic vein. So it is at the venous confluence. So the operation again is extended Whipple, uh, or extended distal pancreatectomy. Here in the duodenum, there is a long distance. So we avoid to travel a long distance in the normal pancreatic tissue. So we withdraw the changing the position, withdraw the echo endoscope to the stomach and try to visualize it from the stomach. And this is the aorta, superior mesenteric artery. And here, this is the splenic vein. Yes, and we try to show it. And this is the venous confluence. You are now in the gastric body with anticlockwise rotation. Yes, this is the superior mesenteric vein, splenic vein, and the portal vein. So we are at the venous confluence, and we notice here that the distance is rather near to the echo endoscope. So we'll travel for a very short distance in the pancreatic tissue. This is important to avoid pancreatitis, and this is a very nice trick. Try not to travel too much or a long distance in the pancreatic normal pancreatic tissue to avoid pancreatitis. Here, the pancreatic duct is not seen. We are now away from the pancreatic duct, and this is very important to avoid pancreatitis. Here it is nearby the venous confluence, and this is not a contraindication because there is no heat sink effect with radiofrequency ablation of the pancreas. It may occur in the liver, in radiofrequency ablation of the liver, but here of the pancreas, the heat sink effect is not prominent. The setting was 40 watts for 10 seconds till we see the veiling or the hyperechoic cloud, or there is a spike increase in the impedance. This is the tip of the needle. We will introduce the tip of the needle to near its most distal part. We used 1 centimeter needle. This is the active part, which will be heated up to 60 and 100, between 160 and 100 degrees centigrade. And now the in place, and we'll start ablation. Now this is the hyperechoic cloud started to appear. And then we can do another pass. This is well ablated part in the center, but the periphery here still there is a viable tissue. So we will do a second pass in the same setting and start ablation again in the second part. Now the veiling increases, the hyperechoic cloud is increased, and we will access this remaining viable part. This is a third pass, third pass in the same session. Yes, this is the tip of the needle. This is the third pass ablation. Now we apply 3 passes. Better not to do more than that to avoid adverse events, especially pancreatitis. And we follow up the patient with clinical and lab follow-up and follow-up CT if it is originally appearing by CT or MRI, but here follow-up with EUS after 3 to 6 months. Now, take-home messages. EUS has a great role in detection, staging, tissue acquisition of neuroendocrine tumor. EUS radiofrequency ablation is a promising technique for small neuroendocrine tumors to avoid major surgery with significant morbidity and mortality. It is especially indicated in surgically unfit patients or patients refusing surgery. Appears of great value in a small, mostly benign functioning neuroendocrine tumor as insulinoma, then gastrinoma. However, more comparative studies are needed before recommending EUS radiofrequency ablation as alternative therapy to surgery for operable pancreatic masses. And thanks for your attention.